genitourinary syndrome of menopause, a very burning issue, and it is a neglected area of the women. The leading questions, they will address this issue. And for that, I want to invite to start this webinar, I want to invite Dr. Anita to say a few words and then we will move forward. Dr. Anita, ma'am, please.
Yeah.
And please display ma'am's CV. She doesn't need any introduction.
No need, chalega.
Chalega. Fine.
Thank you very much, dear Anjana, for being a opening batsman for today's webinar. Anjana rightly told that GSM is a need of an hour. Many a times women are suffering from it. They are hesitant to talk regarding that. And sometimes being a healthcare provider, we are also not asking all that things in details. So better learning is very much needed. It is we can say it is a need of an hour so that we can give better healthcare services to our patients, because many times we know everything, but we are also unable to put it everything in our practice. So during this prescription writing webinar, I am sure that we are learning a lot many crisp messages are given, and in a real sense, we are able to prescribe whatever is needed. Thank you, Anjana.
Thank you, ma'am, for a very nice highlight of the program. Where I think so we directly go to our first topic. Unni, Madam CV, please.
It's okay, Anjana. You can just, we can just start.
Madam CV. Yes. Welcome, ma'am, for your first lecture, the evidence-based role of MHT treatment and the control of GSM. She, ma'am, is a director, Department of Obs and Gynec Department, Jahangir Hospital, Pune. She's been a president of Menopause Society in 2013. She is a representative of International Menopause Society 1526, and she has many feathers to her cap. And madam, the stage is yours. Please, you can start your lecture.
Thank you very much. And thank you for inviting me, Shobha, to this, this prescription writing webinar, which is definitely an unusual concept and really good, as Anita has talked to us about. So we are going to now, can you see my screen? I don't know what's happened to my slides. Can you see my slides?
Go to first slide, ma'am.
No.
Yeah, it was on the first slide. I don't know what has happened to it now.
Just escape key, ma'am. Press the escape key, exit that, and again share the screen.
Yeah, okay. I'll just stop share once.
Yes, now make the presenter view.
Yeah. As soon as I'm making it full screen, I don't know. We just
Ma'am, do one thing.
Yeah, okay.
Press the back skip.
What do you want me to press?
Go to the actually your screen, what we say, presentation view is already running, so that's why it shows that screen. You have to minimize the zoom and escape from the slideshow mode.
Okay, 1 second.
Okay, now.
Is this okay?
Yeah, hello.
Yes, it's okay. Yes.
All right. So we are going to talk mainly about hormone therapy in genitourinary syndrome of menopause. So as Anita was saying, it is basically a cluster of symptoms which is caused by estrogen deficiency of the vulva, vagina, bladder, and urethra. And this occurs in menopausal women, but unlike menopausal symptoms, which usually subside with time, GSM symptoms persist throughout a woman's life, and in fact, some of them may worsen as the woman grows older. The term GSM was coined in 2014 by the North American Menopause Society and the International Society for the Study of Women's Sexual Health. Earlier, we all used to call it either vulvovaginal atrophy or urogenital atrophy, and it's now that this term is being used. God, what is happening? So the prevalence is between 15 to 40%. And the main problem is that there's a lack of awareness because women are hesitant to talk about it. They accept it as a part of aging, and very often they will not talk to us about it unless we ask direct questions. So as far as the management is concerned, there is the International Study for the Study of Vulvovaginal Disease, who say that perhaps we should follow a sequential order of treatment, considering the age, the symptoms of the woman, and her general health, and also looking at her previous treatment options and her preference. And if you do this and talk to her and decide which management she would prefer, then it contributes greater to compliance as well as to adherence, because this is something which may need very long-term treatment. So when they say follow a sequential order, some people will often start with just lubricants or moisturizers to begin with, and then move on to the actual estrogen therapy. So local estrogen therapy, both low dose and ultra low dose, is the gold standard due to its minimal systemic absorption, with circulating estradiol levels persistently remaining in the postmenopausal range. So this is the great advantage of the local therapy, that it's going to address her symptoms and she's not going to have any of the side effects that normally come with systemic therapy. But even so, specific concerns remain in high-risk population, such as breast cancer survivors, especially those under treatment with aromatase inhibitors, because we are not very sure whether this will trigger anything because of the receptors in the vagina. So vaginal estrogens are usually prescribed daily at bedtime for 14 days and then bi-weekly for 3 months. In very severe cases, they can be used continuously for 12 months. We are saying 12 months because that is what safety data is available for 12 months. But having said that, most of us have seen women where either we continue it or we stop for a short while, and when they come back with symptoms, we have to give it to them again. So estriol is a very weak estrogen, and that is the dosage is 0.5 milligrams per day. It comes in with an applicator, and the estriol content is 0.5 milligrams, or you get a conjugated equine estrogen cream, which is 0.3 milligrams per day. So we usually tell them to use it at bedtime. Now, estradiol and estriol are also available as vaginal tablets. These are, I'm talking about things which are available in India quite freely, actually. There was a time in between about 6 months ago when we were not getting the estriol cream easily, but now that is also available. And the estradiol or estriol vaginal tablet is also available. And some women prefer tablets to creams because they find the creams very messy. The main advantage of using vaginal estrogens is that there is no need to add progestogen, because lots of studies have been done which show that it doesn't really stimulate the endometrium even on long-term use. So if there's only genitourinary syndrome, so either urinary or vaginal symptoms, then there is no need to give the woman and expose her to all the side effects of systemic menopausal hormone therapy. Estriol, as we all know, is the final metabolite of estrogen synthesis. It is a short-acting molecule, and it's very efficient when used intravaginally. This is probably because it has a greater relative affinity for the estrogen receptor B than for the alpha receptor. So the beta receptor is in more abundance in the vagina. And since it doesn't act so much on the alpha receptor, it leads to very few extravaginal effects. So there have been several systematic reviews looking at the treatment, and one of them, which looked at 20 randomized control trials on the use of isolated vaginal estrogen for up to 52 weeks, showed that the rate of endometrial cancer and hyperplasia was only to the tune of 0.03% for cancer and 0.4% of hyperplasia. So it shows that really the local estrogens are very, very safe. Now, this is another review which looked at 4,500 women who were using vaginal estrogen for a year, up to a year of treatment. And they found that mild transient candidiasis was common, and usually this did not require any treatment. Overall, the incidence of vulvovaginal mycosis was 0.73%, vaginal bleeding 0.75%, endometrial hyperplasia 0.06%, and out of these 4,500 women, only one case of endometrial cancer was found. So we can be reassured that local therapy is really, really very safe. Now, in a woman who has both climacteric symptoms and vulvovaginal symptoms, so some women will present with hot flushes, insomnia, night sweats, mood swings, and they may also have vulvovaginal symptoms. In this case, you could just start with systemic hormone therapy. Such women may not need local therapy at the outset, because systemic therapy quickly restores the characteristics of the vaginal epithelium, decreases the pH, and increases the lubrication. So even the dyspareunia is resolved with that. But systemic therapy, as I've said, is not to be used solely for genitourinary syndrome of menopause. Now, then there is also DHEA. There are androgen receptors which have been identified in the vaginal mucosa, and a vaginal application of 6.5 milligrams daily. Now, this particular dosing of 6.5 milligrams is not available. We are getting a 25 milligram capsule, but they have found that 6.5 milligrams daily converted to estradiol and testosterone, and 12 weeks of treatment was associated with improvement in dyspareunia, pH, and vaginal maturation, and there were no endometrial changes, and there was no increase in the serum estradiol levels. Ospemifene is a SERM. It's a third-generation selective estrogen receptor modulator, and is the only oral treatment which is currently available for the treatment of genitourinary syndrome. It is available of 60 milligrams daily, which is used orally. It has an estrogen agonistic effect on the vagina, and it is antagonistic on the breast and endometrium. And so it can be used very safely in the vagina. And there are more and more, there's more and more safety data coming up. It reverses the symptoms and delays the progression of the GSM. And it has been approved for use in dyspareunia in several countries. And this review in the climacteric of 2023, this volume 26, the entire volume of this climacteric edition is on GSM. So those who are really keen, please read all the things in this. Much of what I'm talking to you is taken from that particular issue. And earlier we used to think that because it is a SERM, ospemifene, also the DVT risk is as much with all the others as with the other SERMs. But recent evidence has shown that the DVT risk is low, so it's quite safe to use even in elderly women. Now, the problem is with breast cancer survivors, because though there is reasonable amount of safety data with estrogen in breast cancer survivors, Usually the oncologists are not very happy with us using estrogen therapy, even for local symptoms. So non-hormonal is the first line. So moisturizers and lubricants, they are very safe, but they have limited efficacy. So in women who are really suffering, because now we are seeing more and more of these breast cancer survivors, because in our country, breast cancer comes at a younger age than with in the West. So women are getting breast cancer between the ages of 40 and 45, and they have many years after their treatment to live with these symptoms. So people are looking at all the options. And DHEA, this was a pilot study, but they're expecting more data in a few years in breast cancer survivors on aromatase inhibitors, because this is the group they are concerned about. They used 6.5 milligrams of DHEA every 48 hours, so on alternate days for 6 months. And the GSM improved and the serum estradiol did not increase, so they were not worried about recurrence. And ospemifene data has come out where they've looked at it in breast cancer survivors, and there's no increase in the recurrence in those women. And in women who did not have breast cancer, there's no increase in the incidence of women also, even in women who have completed adjuvant treatment. So the North American Menopause Society in 2020 said low-dose vaginal estrogens, vaginal DHEA, systemic estrogens, and ospemifene are effective treatments for moderate to severe GSM. And when low-dose vaginal estrogen or DHEA or ospemifene is administered, a progestogen is not indicated. However, endometrial safety has not been studied in clinical trials beyond 1 year. And there was a meta-analysis in 2024, and they also reached a similar conclusion. The Indian Menopause Society, in their 2020 guideline, have said the treatment for these women should be started early to prevent irreversible atrophic changes. They may need long-term treatment to maintain benefits. Some women on oral estrogen therapy may require additional local therapy. So you might have started MHT for their vasomotor symptoms, and later they've developed GSM, and they're not that much benefited because they've already been on oral estrogens for a while. So then you may need to add additional vaginal therapy. Treatment may be continued indefinitely, but safety data do not go beyond a year, which is why usually we may take them off it for a few months, and when their symptoms recur, we put them back on it. So endometrial surveillance is not required in asymptomatic women. Unscheduled bleeding should be investigated. And besides the other normal symptoms of GSM, even women with recurrent UTI and urge incontinence may benefit from the local estrogen therapy. So I would like to conclude that by saying that all of us know that GSM is a common and distressing syndrome, and there is a hesitancy in women in talking about it. So we should initiate the conversation, and we should ourselves be convinced that vaginal estrogens are effective and safe. As far as recurrent UTI is concerned, please, with symptoms of UTI, just don't start antibiotics. Make sure that cultures are there and use the cultures to guide the antibiotic therapy. And if the cultures are negative, then please do consider using local estrogens. Thank you very much.
Thank you, Dr. Jyoti. It was a very nice, crisp message, and you covered all the point. Now, anybody, if you have any queries, can
Thank you
Hmm.
so much, Jyoti ji. That was a lovely talk. Actually, I was thinking that you will have more, you know, uh, a little bit more elaborate on somehow on the local tissue changes which we can expect. Like, is there any way to objectively assess how much of improvement is happening? So, like for example, if we can measure some cytological indices, is there any need to do that thing, whether the hormonal therapy is working or not? And once we start a vaginal estrogen therapy, when do we call them back? And what kind of follow-up is needed? That is what I was interested in knowing.
Okay, so no, I don't think any tests are required unless the woman has been using it for 3 to 6 months and is not showing improvement.
Hmm.
Then you might need to test, but otherwise, routinely, just her subjective feeling of getting better is
Hmm.
quite adequate. We don't need to do any tests.
Hmm.
And sorry, what was your other question?
No, I
Follow up.
wanted to
So,
know, correct.
yeah.
How often to
So,
follow?
yeah.
How
So,
long? You said safety data for 1 year for
yeah.
most of these preparations, right? Hmm.
Yeah, for
Hmm.
all the estrogen preparations, the only
Hmm.
concern was with conjugated equine estrogens. And that is why, if you're giving it for a long term time,
Hmm.
I would say that use the estriol, because it's such a weak estrogen that we're not concerned really at all about it. So, in women with who have very severe symptoms, or where you're seeing that even the vulva is all, the labia are all
Hmm.
very atrophic, you could start with conjugated equine estrogen cream because it works faster, because it's a slightly more potent
Hmm.
agent. You could use it for 3 months,
Hmm.
and then for continued therapy, or if you stop it and the patient comes back with symptoms, you could then shift to estriol. But for the average woman who just comes to you at the first visit with GSM, between the ages of say 45 and 60, it is quite okay to use estriol cream as the first line agent if she doesn't have contraindications like being a breast cancer survivor. And I don't see my patients back till 3 months.
Hmm.
I tell them that you could come back if you have a problem, but do not expect miracles. Nothing is going to change in 1 week or 2 weeks, so there's no point seeing them that quickly.
Correct. Hmm.
And so
Usually
I
for
usually,
6 to 7 months, probably we cannot make out any subjective change and objective change. So it's very difficult to have
yeah,
any kind of feel. Yeah. So 6 months, I think, by the time they
yeah,
come.
they come. So,
I have
even if you
two
want
more
to see,
questions,
yeah,
but I would
sure.
like others to come in because then
Yeah.
only I will be asking you. Anybody else, please, or any comments so that.
Anjana, say for example, once the symptoms are relieved, subjective relief, you just stop the treatment. Or you will abruptly stop or taper it off. Or is it that you will ask them to come back if they have symptoms, then you have to start again. So
Yeah,
any type of recommendation like
right. So there's no recommendation in the guideline about when to stop and when to start. But generally, after 3 months, if they are subjectively, I see them after 3 months. I don't wait till 6 months. If they're feeling subjectively fully relieved, then only I would stop the treatment. If they are feeling just better but not completely relieved, I would continue for another 3 months and tell them that when the symptoms recur, they can restart and come back and see us at that time. They don't have to come back every time to see us unless they feel that they're not getting relief, or they've used the agent for a little while and they'd just like to see. As a routine, once a year we should see them. So once a year as a routine to check everything else also. But just for their GSM, to restart their local estrogen, if they don't have contraindications, they can restart it after a month or two whenever you've stopped
Hmm.
it, and if they get symptoms again.
They themselves can restart.
Yeah,
That is a
they
good
can
message.
restart.
Yeah.
taper off.
But they
Abruptly
should
There's a
come for a
or
question.
follow-up.
tapering it off.
Shobha, there's a
Abruptly,
question.
you don't need to
Hmm.
taper it
Hmm.
because it's
He-
a very low dose as it is, so you don't
hmm.
need to taper it. You can just stop it abruptly.
Yeah.
So there's a question where it is CE or estradiol tablet, progesterone is not needed. If we have prescribed beyond 1 year, then what about adding progesterone?
There is no data to support the use of progesterone, even if you're using it for more than 1 year.
So I think
I,
the clear message is gone. If we are using a
yeah.
local estrogen, we don't need any
Local
progesterone.
estrogen, yes, yes, that was very
Very
clear
clear and crisp message
from whatever
to
we are reading
everyone.
today, and
Yeah,
she's Dr. Jyoti has also confirmed that.
yeah.
My question is next: is ospemifene available for us? All of you are using it because
It
that
was
seems to be.
available. Yeah, it was available for a short time.
Short time,
But
that's what I
yeah, but it's not available. At least in Pune, we are not getting
No,
it
no, it
anymore.
is
not getting. Even in Bangalore, we are not getting. What about DHEA? DHEA?
DHEA, the 25 milligram ovule was available. Again,
Was
I have
available.
not tried it in
It's a
recent
vaginal
times.
insert, right? It's a
Yes,
vaginal
vaginal
insert.
insert.
Okay,
Is it,
so then we are actually stuck with local estrogen. There's
Yes.
one more question I have. In any time,
testosterone gel is available? Testosterone
Vaginal
DHEA gel is not
testosterone
available?
gel is not available.
not
Not
available.
available.
The other thing is, do you need to think about starting systemic therapy if local does not work at all? Have you had any such occasion? And of course, within the age limit of 60, I'm not asking for more than that. Within that, would you start systemic therapy?
Well, if she doesn't respond to vaginal estrogens at all, definitely if she has no contraindications, I would try
Correct.
systemic therapy.
Yes.
But it's an unusual occurrence. It usually occurs the other way,
Hmm.
that you've started systemic therapy for vasomotor symptoms, and though she's on the systemic therapy, she still comes back with vaginal symptoms. That happens more frequently than the reverse that you have asked about.
I too feel when it is not responding to local, then what benefit are you going to get by systemic?
No. The thing is, sometimes you know, you never know. Sometimes it does work if you use both and not one. Maybe in the younger subset, may not be in the older women where the vascularity also has reduced.
Even
And
sometime.
also, when do you? The next talk is about that. But complementary therapies, what do you feel apart from HRT? Complementary therapies.
I have no
Adjuvants.
experience with that, so
No.
we'll wait for Agnes. Definitely, pelvic floor rehabilitation exercises definitely has been shown with data to help.
Correct.
So you don't have to do, so that sort of thing is fine. You can explain to them. And of course, as we all know from earlier also, sexual intercourse is something which definitely helps.
Yes.
So
Yes.
that these are things which you can tell the woman that, but I'm not talking about complementary therapies in terms of actual therapy. But pelvic floor rehabilitation, just by them doing the pelvic floor exercises, that increases the vascularity in the vagina and helps their GSM. There is
Actually,
data to prove this.
Can I
especially if
ask
there is pelvic organ prolapse, especially if there is pelvic organ.
Dr. Jyoti?
Yeah, Dr. Parima.
Because it was a very good talk. And anything like screening is a must before, of course, it's a local estrogen cream, but still screening with pap smear or anything is a must, or just we can go ahead if she's
No,
not following.
yeah, if see, screening is required because you should do opportunistic screening, but it's not that you have to do screening before giving local estrogens. Very often it's in reverse. You do a pap smear, you get an ascus, or you get and you might need to give her local estrogens and repeat the test after 2 or 3 months, because the atrophy itself, they are unable to distinguish it from LSIL. So you will often get an ascus report. So if the cervix and vagina look very atrophic, it is prudent to use a local estrogen cream before taking
indicated, more so indicated. Okay, thank you.
Thank you, everyone. It was a very nice discussion. Now we move forward and have a new topic, solution for laser therapy in GSM. And I want to invite Dr. Ragini Agrawal for the lecture. We all know her. She is the present General Secretary of IMS. Madam's CV to be displayed.
छोड़ दो
क्यों छोड़े नहीं छोड़ते
मैं ही कर देती हूँ
मैं थोड़ा कोशिश कर रही हूँ ज्योति मैडम से थोड़ा सा वेट करने के लिए थोड़ी देर till we write the prescription.
Madam CV was down in 2 seconds, but it is a very huge LOS she has in her cap. So, ma'am, you can directly go for your lecture. Yes, now it is back. She is the General Secretary of IMS. She has many awards. She has many publications. She is an editor. She is an
बस
author.
बस हो गया हो गया हो गया मैं आगे कर रही हूँ थैंक यू
She is the director of her health, her life matters, Gurgaon. Madam, now the stage is yours, and let us.
चल क्यों नहीं रहा है
Okay.
so thank you so much after a crisp clear talk of Madam Jyoti, I'm going to talk about something which is next way if we are not able to use hormones or it is refractory. So I have little change my topic from the laser to the regenerative medicine in GSM because many times we give the combo therapy. It is not only laser and other things has also come up. So with blessing of God and gratitude to all, what we are going to discuss today is what is energy-based devices, what is its role in the GSM patient, and GSM and UI. मैं कुछ और बोल रही हूँ क्या एक मिनट हाँ GSM So there's certain thing we have to remember with the hypoestrogenic condition. There is the changes in the vaginal mucosa, and sometime the woman present with the even along with the SUI, and there's a vaginal trophy, dryness, and it leads to a physiological distress. So we have a various modalities we have to manage these condition. So what we do with these lasers, basically, these energy-based devices, whether it is lasers or radio frequency, they apply thermal or non-thermal energy to the various layers of the vaginal tissue, stimulating collagen regeneration, contracture of elastin fibers, neovascularization, and they improve the vaginal lubrication. So these energy-based devices is the generation of the heat, thermal heat, which causes the physiological modifications to the human tissue. What happens when we give this laser or RF? It increases this energy increases the temperature of the water, that is 40 degree to 42 degrees centigrade, which causes collagen contraction. The matrix of the vaginal wall is made of collagen. That is usually in the younger woman, it is type 1 to type 3. And in the older woman, it moves to the type 5, which has a less strength. And not only that, the changes in the cells are there. There's a less vascularization, and it all leads to the less of the flora and the less of the lubrication and the dryness and less of the growth factor. So all these things can be reversed by the laser or the RF or the adjuvant use of the adjuvant. So this collagen is an important component of the pelvic floor supportive structure, and it is more of the 80% the protein content, provide tensile strength, and as I told you, the type is very necessary to know, and this change in the ratio toward collagen 3 to 5 is most frequently observed in the vaginal prolapse. So here lasers are being accepted now, many regulatory bodies also as one of the modality. Still RF, ultrasound waves and the HIFU, these things are not accepted. The carbon dioxide laser is one laser which has come in the market first in 2010 for the menopausal woman rejuvenation only, and now many Ayuga and all NAMS, these are societies, they are, although still they are not totally accepted because the RCTs are not much available, but they are saying yes, they are safe and we can use the carbon dioxide laser for the rejuvenation. So what is basically the laser? This is a type of energy from the electromagnetic spectrum, and it travels in a waves and a very broad length from the DC voltage to the short wavelength. So it is present in many type of energy, but what we are using is a infrared. So this light, whether it is harmful, your answer is no, because this is not causing any ionizing, non-ionizing reaction and changing a cells towards the some abnormality. And we all know these menopausal changes is the eternal truth of the woman. And GSM is a chronic progressive vulvovaginal, sexual, and the lower UTI conditions by a broad spectrum of the signs and symptoms, which we uh, recently learned by the Jyoti Uni madam's lecture. And it affects almost 50% women. And somewhere there's a limitation with the HRT or the lubrications. It is a high incidence in the prevalence and impact, the negative impact on the quality of life. And many a time we need a non-hormonal regenerative options. Here, this gap is fulfilled by this laser and the adjuvant therapy. What happened when there's a GSM? There's a genital symptom, there's a sexual symptom, there's a urinary symptoms, and collectively we call it as a genitourinary symptom. And in the pathophysiology, when we see there's a functional changes in the form of the changes in the vaginal epithelium, increased vulnerability in the physical irritation, there's a predominant basal cells, and in the postmenopausal women. So we can talk about the vaginal maturation index in these women if we really want to say that yes, she has got some effect or not. There's a emergency call from the labor room. I have to take just for a second, please. Huh? But vaginal health index score is a very important health index score, which we can do very easily in our OPD and give us as a subjective finding, where we have to see pH, moisture, and the consistency of the fluid, rugosity, elasticity, length of vagina, thickness, epithelial, and the vascularity, and we can give this score. Now coming directly to my topic, that is a carbon dioxide fraction laser. It has been safely used on the skin of the face, neck, and chest. And although FDA cleared for the use of this carbon dioxide laser for a bigger thing, like incision, excision, vaporization, and coagulation of the body's soft tissue, but somewhere maybe the pitching of the market is bad. They are not pitched more for the rejuvenation of the regeneration of the vaginal tissue, but they have pitched for the other things, most of the cosmetic use, that is absolutely wrong. So it is not FDA still given a forego for this treatment. But we have found out in our 10-year practice, it has a very good role. Here, laser energy is delivered to the target tissue through a specially designed scanner. There is no charring. It is a microablative laser and is passed through a pixelating holographic lens, forming a small spot size. And it is a thermal effect is achieved in microscopic columns surrounded by the spared tissue, from which the healthy cells are recruited to accelerate the healing process. The advantage is it is minimally invasive, virtually painless, gentle treatment for controlled safety, maximum precision with the carbon dioxide laser, fast, efficient, no post-treatment downtime, and there's an excellent patient satisfaction and long-term success. What happened with when we give the laser, there's a cellular level changes in terms of the photostimulation, photodynamic reaction, and the photothermolytic reaction. Laser is absorbed in a chromophore, and this chromophore absorb this energy and scatter inside the tissue and transmit beyond the till it is absorbed in the chromophore. So there's a thermal damage leading to the superficial shrinkage and the deep aseptic wound and the collagen remodeling. In first phase, there's an early thermal effect leading to the edema, release of the chemical mediator, shrinkage of the collagen elastic fiber. In the phase 2, which we do after 1 month, there's a proliferation, there's a fibroblastic recruiting, new extracellular matrix, and new collagen fiber. Phase 3, there's a remodeling. So there's a physiological and the functional recovery of the vaginal mucosa. If you see this diagram, this is a only diagram which came in the market from the Mona Lisa machine, is the histologically proven biopsy in the younger woman. First is a younger woman vaginal mucosa histology. Number 2 is a postmenopausal, And number 3 is after laser treatment. Although it is not absolutely like the older woman, younger woman, but it has regained a lot from the middle slide from the older woman after the laser treatment, like a younger woman. So it is other energy-based devices. I will not go in detail, but if you see this diagram, the carbon dioxide laser is only on the surface here. So what it does is more effect in the only the mucosa. So there is no chance that there is what I can say is injury to the bladder or rectum. But in a postmenopausal woman, when it is a very thin and very parched like the vaginal skin is there, we prime it with the estrogen before starting the treatment. Otherwise, there's a trauma, there's a bleeding, and if we give the 3 months of the priming, then it is easier to negotiate with the laser probe inside the vagina. The second part is the platelet-rich plasma, which we are using as a combo therapy sometime. And we all know it is a form of the regenerative medicine which harnesses the natural growth, and it is method that uses a centrifuge blood fraction containing a high concentration of the platelets in a small volume of the plasma. The beauty of this, it is a autologous. Patients own from own blood, we make it, and it releases the growth factors like PDGF, VEGF, TGF, and promotes angiogenesis, collagen synthesis, and the tissue regeneration. So I will not go in such a detail because there's a lots type of the granules are present which give different type of the growth factor, and it is used widely in a different branches also. So key point for preparation is you have to see the patient hemoglobin, platelet count, go for the viral marker. You have to draw blood with a wide bore needle. So you don't clump the platelets, don't do the injury, and anticoagulant ACDA is used, and concentration should be very good when you come up with the platelet plasma. So this is a PRP kit which you use. It is better to use the commercial kit always, and still there's a small RCTs and the pilot studies which has shows that improves lubrication, reduce pain, it promotes epithelial thickening, vascularity, elasticity, but still we don't have so much of the RCTs. With this, it is an advent to the standard therapy. So how we make? We first draw the blood, then centrifuge it first, centrifuge, and take out the upper clear plasma, leave the downside the red cells, and then this platelet poor plasma will again be give a spin by the second centrifugation and take out the upper lighter area, that is the poor plasma, and in between there is a dark color band, that is the rich plasma that we take and inject. Now we are not even discarding the poor plasma also, because it also has some growth factor. After injecting the rich plasma, we inject that plasma also. So there's a closed technique with the new tubes, new preparations, and even the exosome is another thing which has come in the market. And many a time people are replacing the PRP with the exosomes. So how we give? There are two techniques. One is the injection technique when we give in the vaginal walls, anterior vaginal wall, introitus, clitoral hood. But what I do, usually with the carbon dioxide laser, there's already aseptic wound is formed, because laser give the needle, it goes like inside and make the small holes. So in a very low energy, I give the carbon dioxide laser, and it causes the holes, but not too much of energy. So it will with not the main treatment, but I call again an in between. And with this hole, I just push the plasma inside and it will seep inside the vaginal wall by itself. Otherwise, you can give with the needles also. So patient selection in the GSM unresponsive to topical therapy, estrogen contraindicated, all those breast cancer survivors, but should not given in the cases with the active infection, bleeding disorder, platelet dysfunction. Please take an informed consent off label, experimental, but it is very, very good for the woman or the post cancer or reluctant to use the hormones, and set realistic expectation. Timelines usually 2 to 4 weeks improvement, repeat session every 4 to 6 weeks, 3 session of the laser and the 3 session of the platelets, and usually there is no adverse event. So it's a combo therapy. Many a time we require, that is PRP plus laser plus HRT. So it is a multimodal GSM care which our women need, and we should really give them. Thank you so much for your patient hearing.
That was lovely, Ragini. अच्छा था. Yes, yes. Let us hope आपके सेंटर से एविडेंस आना शुरू हो जाना चाहिए. We want a publication from you. Yes, yes. No. We want a publication on Indian women.
We are very bad about that only.
नहीं वो करना पड़ेगा आपको, because whenever we try to read, we find no evidence.
No, there's lots of literature is there. Even the biopsies are also there.
That's what. So we are hoping it comes into grades of recommendation, just like 2B, 2C is there for hormonal therapy, like that. Revati madam, I request you to go ahead with your talk. Anjana will introduce you.
Just a minute. Ragini, have you compared this laser with this PRP? Which is better, or which is comfortable for the patient? Because cost-wise, definitely PRP will be cheaper.
Madam, I usually do the laser, and my patients are very happy with the laser. Sometime in few cases when I saw it is too much of the dryness, or patient needs some sexual gratification also, I add PRP also, but I'm very happy only with the laser. Only PRP, I have never done it, but few of my friends, they have done, especially if you don't have the laser machines. You can start with the PRP, because few of the friends have given this thing that they are getting the good result with the PRP also. What we want a angiogenesis, we want a neocollagen fibration and the lubrication. And with the PRP, we know that it is going to improve these factors.
Yeah.
So we have never done alone PRP, so I can't say.
Ragini, Rinku Negi पूछ रहे हैं, how or when do we assess adequate response to laser? How long does it last? And do we have to repeat therapy, and till when do you continue this exercise?
Number one, it is just like she does not have any hormone. It is a support. So she will need, yes, 100% it is a repeated procedure. And in the first go, we do the 3 sessions with a month's apart. And then after 3 sessions, depending upon the patient's feedback, 8 months to 12 months, there's a repeat memory session is must. Usually what I found in a very older patient, say 75, 80 years old woman, where there's a very bad type of the GSUM we see, they usually come in the 6-7 month. We need one more session. So after the full treatment, 6 months to 10 months, they come for another session. That is usually the younger patient, they don't require. And these older patients, they are very reluctant even to use the estrogen cream, because sometimes it is not possible for them to use the estrogen cream. So this is my take. Patient, it's a not one-time treatment. You need a repetition. Even for the Botox, filler, whatever you give on the face, after year or 18 months, patient needs again Botox 3 to 6 months. So these are the therapies which need a repetition.
Yeah. And
estrogen cream also, you give a estrogen cream, patient is okay, then she will come again, no, I have again developed. So basically you cannot remove the root cause. What she is suffering, the root cause is the hyperestrogenism. It is in the body.
Wohi Ragini, so the message is that both are temporizing only, right?
Yes,
And
everything is
yeah, both are
temporary.
correct.
Everything is
Temporizing
temporary.
measures only. So it
Yes.
is not like a cure. It is
No,
like
no.
a temporary relief of symptoms,
Yes.
and we have to improve with other methods like with the local circulation.
Shobha, the question is
Hmm.
that every treatment of the postmenopausal woman is a temporary method. Whether in the osteoporosis, you are not going to cure. You are go on. You have to give those all the medication. Years together. When you stop, after some time, it come back because there's no estrogen in the body. Until as we get some genetic therapy to introduce the permanent estrogen in the body, everything is a temporary in the menopausal women.
There is and one more question: can lasers be given for cancer patients?
Yes, because it's not a hormone, not at all. It's a best modality to use in the specifically in the breast cancer survivor. Whatever we can say, they are not going to use the estrogen cream. Even their oncologists, they are very reluctant, specifically if they are ER/PR positive.
I think Ragini will go ahead.
Yeah.
Ranjanaji, please bring in
Yes.
Dr. Revati, and after that I will do something.
Okay.
Thank you, Dr. Ragini. It was a very nice lecture. Very nicely elaborated the technology and how it works on the skin and the mechanism. Now we move forward to our next session, which is by Dr. Revati Janakiran. Sorry, Janakiram. Ma'am, sorry. I want Madam's CV to be displayed. Hello. Hello.
And just start sharing my.
Madam, CV to be displayed.
1 minute, ma'am.
Next, after this, next. Yes. Professor Dr. Revati Janakiram, she is a former director IOG Chennai, Vice President of Foxy South Zone 2016, President of Tamil Nadu Fox, I think so, Obstetric Gynec Society, that is in 2023, founder and secretary and past president of Madurai OBGY Society, has been a founder president of Madurai Menopause Society. She has been a recipient of many awards. She has contributed to the chapters, and she has even received a Pride of Foxy Award in November at Mumbai. Madam will be talking about a very new subject, which is prebiotic and probiotic in menopause. And I think the role of prebiotic and probiotic, and think these things are now very new coming, and they really make a huge impact in the treatment. So Madam, please, you can share your slides and you can talk about the topic.
Thank you, Anjana. After hearing this expensive laser and a little worrying hormone therapy, let me talk about this pre and probiotics. We know the impact of the microbiota on the vaginal mucosa, and therefore it is very important to know about the pre and probiotics in the management of genitourinary syndrome of menopause. We know it's a condition affecting the postmenopausal women, characterized by vaginal dryness, itching, and pain during intercourse. And the symptoms are often linked to a decline in the estrogen levels. That's why we are replacing the estrogen many a times. Okay. Now, it is estimated that around 50% of the women who are reaching menopause every year suffer from the symptoms of GSM. But remember, the symptoms are not due simply to lack of estrogen. And one possible contributing cause of symptom is the vaginal microbiota also. Vaginal microbiota is a dynamic entity, and it plays a critical role in the pathogenic interplay of postmenopausal changes. Now, how the probiotics is linked with the vaginal health? You know, the lactobacillus is the most abundant microorganism in the vagina. It is related to the vaginal mucosal barrier. It produces lactic acid to maintain the low pH, which acts as a defense against any infection. It also adheres to the vaginal epithelium and can competitively antagonize the colonization of the pathogens. So the factors produced by the lactobacillus like bacteriocin and hydrogen peroxide, all these things can inhibit the growth of the pathogenic microorganisms. Therefore, probiotics can play an important role in maintaining the stability of vaginal microenvironment, thereby improving this immune defense. Probiotics have been spotlighted as a promising intervention to assist the reconstitution and maintenance of the vaginal microbiome. Now, what happens in menopause in the vagina? There is a dysbiosis, these changes in the composition of the microbiota in the vagina. This may play a role in GSM. Estrogens regulate the microbiological environment of the female reproductive tract by maintaining the epithelial thickness, glycogen levels, mucus secretion, and also decreasing the vaginal pH through promotion of the lactobacilli colonization and lactic acid production. So consequently, when there is a reduction in the lactobacilli during menopause, the shift in the microbial composition suggests that, okay, oral probiotics containing the lactobacilli can play a pivotal role in promoting the vaginal microbiome eubiosis. Thereby, it can help in the management of GSM also. Now, while new evidence on the role of lactobacilli in premenopause is emerging, the role of lactobacilli specifically for GSM is not yet very clear, but there are evidences. Some reports show promising data on the effect of probiotic therapy in menopause. We know very well that probiotics in so many other health problems, it has been proved beyond doubt. But for GSM, this literature evidence is slowly coming up. Now, in the literature, there are only few studies at present and small population samples on the role of exclusive therapy of lactobacilli, and further data are necessary. Now, let us see the trials. As we know, the treatment options for GSM include on one side estrogen therapy and on the other side non-estrogen therapy. Now, recent studies have found that probiotics, when combined with the estrogen, can alleviate the related symptoms caused by the vulvovaginal atrophy. Pertisevic et al. In 2008 found that in a randomized controlled study of oral probiotics in postmenopausal women, he found that there is a significant reduction in the Nugent score and improvement in the GSM symptoms also. These results suggest a compelling alternative approach to restoring the healthy vaginal flora in postmenopausal women through a targeted use of specific probiotics. And again, Ribeiro in 2018, they did a trial with estrogen alone and estrogen with probiotics for GSM. Compared with estrogen alone, estrogen combined with probiotics significantly improved the GSM symptoms, mainly the vaginal dryness, dyspareunia, and increased the vaginal health scores also. And in 2021, Lim et al. Found that the intestinal microbial composition changed after ovariectomy. So that is in an animal study. In ovariectomized rats, they found that after ovariectomy, when they supplement the new intestinal lactobacillus strain, it significantly reduced the climacteric symptoms and also promoted the integrity of the intestinal barrier by increasing the messenger RNA level of tight junction related markers. Now, how exactly can you expect the probiotics to help in the management of GSM? Obviously, it restores the vaginal microbiota balance. It is very, very clear. So, the probiotics can help replenish this beneficial bacteria, thereby restoring the healthier vaginal environment. Maybe through that, it can help in the improvement of the GSM symptoms. Then again, reducing the infection risk, especially the urinary tract infections, okay, because the vagina and the urinary tract share the same estrogen receptor epithelium. Okay. And alleviating the symptoms, significant reduction in the symptoms like vaginal dryness, itching, and painful intercourse. And it manages the vaginal pH also, obviously, because of this production of lactic acid. And another additional benefit is that there is an enhancement of the hormone therapy effect. Some research indicates that the probiotics may enhance the effects of the hormone replacement therapy for treatment of GSM. Another interesting thing we have to note is that the gut microbiome and menopausal health. As you can see here, the circulating estrogens go to the liver and get metabolized. Now, the conjugated estrogen is going to be excreted through the intestine in the feces. But when this conjugated estrogen enters the intestine, the gut microbiome, that's called estrobolome, it deconjugates the estrogen and bring it back to the circulation. This enterohepatic recirculation of estrogen is brought by the estrobolome, that is the gut microbiome. This point we have to make a note of because this is going to have a link with our menopausal symptom. And the gut microbiome, with its capacity to deconjugate and recycle the estrogens, it may play an important role in determining the level of estrogen post-menopause. That just now Ragini was telling, there is no estrogen in the post-menopause, and that is the reason for all complications. Let us bring back the estrogen through probiotics. Now, given the potential to modify the gut microbiome through specific prebiotic or probiotic tracks, the gut microbiome represents an unexplored new frontier in peri as well as postmenopausal health. The gut microbiome could be harnessed to improve the menopause symptoms, effectiveness of hormone therapy, or menopause-related other health outcomes also. Now, in that case, which is preferable, vaginal or oral probiotics? Now, increasing the vaginal lactobacillus levels may offer an enhanced protection and decreased rate of urinary tract infection. It is very clear. Now, literature review of published studies looking at the role of estrogen and probiotics found that we know very well that always estrogen compared to systemic local estrogen is much, much beneficial. Same way, local probiotics definitely is better than oral probiotic. So topical application of the probiotic creams improve the level of lactobacillus level as well as they are more effective than the oral probiotic. But what is the role of the oral probiotic? They are easier, better compliance, and it is easy to regulate also. Now, how the vaginal probiotics act? Obviously, they restore the vaginal flora, alleviate the symptoms, reduce the risk of infection, and also complement the estrogen therapy, as I told you earlier. So we can use the probiotic either as a vaginal gel or alongside probiotic soap and cream. All these things have been found to be having a larger improvement of GSM. Now, vaginal probiotics may turn into therapeutic solutions as the composition of vaginal microbiome and conditions that lead to dysbiosis are now better understood. More research in the vaginal microbiome field will help to create strategies for improving the effectiveness of the vaginal probiotics in future. Now, what about oral probiotics then? We are all using that, many I believe. And oral probiotics may be an alternative to vaginal probiotic. That has an advantage because especially in considering the regulatory hurdles in some countries, mainly the patient compliance, and oral probiotics are easier to regulate given their wide usage and others established a safety profile in various demographic cohorts. Furthermore, they may be integrated into routine dietary habits, fostering long-term compliance and adaptation among the women. However, further studies are necessary to evaluate the benefits of oral probiotics of the women health. Now, before prescribing probiotics, we should consider certain things. Just like that, the patient cannot get it over the counter, and the patient should get the consultation of the healthcare provider. This is very, very important because it is not a replacement of estrogen therapy. Okay. We know very well that once there is an irreversible damage in the vagina in GSM, it is very difficult to revert even with the estrogen therapy. So a proper treatment must be given at a proper time. So without consulting the healthcare provider, they cannot just like that take. And another important thing is that specific strain must be used. Different probiotic strains may have varying effects. So it is very important to choose the products with strains that have been studied for specifically for GSM. Only that has to be used. And probiotics are not a replacement therapy, as I told earlier, just like a vaginal moisturizer or a hormone therapy. And while research on probiotics for GSM is promising, of course, more studies are needed to confirm their effectiveness and determine optimal dosage, which strain, and all those things. Now, a little more about the specific strain. A probiotic strain is identified by its genus, species, and an alphanumeric designation that identifies a specific strain. In fact, while many clinical studies have relied on 16S RNA sequencing to characterize the microbiome, its limitations in strain level resolution and functional insights prompt a shift towards the shotgun metagenomic sequencing and other advanced methodologies. The success of a probiotic intervention depends on how well it interacts with the host specific factors and bacterial strains and its ability to adapt to the host environment. Now, we have to know which strain is beneficial for GSM. Now, there are some expert recommendations for use of probiotics in treating bacterial vaginosis, as all this lactobacillus rhamnosus, this, that, and all, and that has to be continued for 4 to 6 weeks. A follow-up of 1 to 2 months post-treatment is advised. Similarly, for recurrent urinary tract infection also. Now, what about prebiotics? You have to distinguish between pre and probiotics. Prebiotics are food for probiotics, whereas probiotics are live microorganisms that can be beneficial for vaginal health. Prebiotics, which are non-digestible food components like certain types of fiber, this promotes the growth of beneficial bacteria. It can play a role in managing the symptoms of GSM by potentially improving the vaginal microbiome. While research is ongoing prebiotics may offer a supportive role in maintaining the vaginal health and reduce the severity of GSM symptoms. It can bring back, of course, the balanced vaginal microbiome and can contribute to improved vaginal lubrication, reduced irritation, and also decrease the severity of symptoms like dryness and discomfort. But again, I repeat, remember, prebiotics are not a cure for GSM. They may be a supportive component in managing symptoms and promoting the overall vaginal health. Again, in 2020, there was a study that combination of hormone therapy with probiotic support can be an effective treatment option for GSM since it helps to enhance the proliferative process, improve the blood circulation, restore the biosynthesis, and relieve the dyspareunia. Just like the laser, this also does everything. And its effect on the condition of the vaginal epithelium was comparable to that of local estriol monotherapy, whereas it was significantly more effective for eliminating the symptoms of sexual dysfunction. So a combination of estrogen, local estrogen with local probiotics have been found to be very, very useful. And recently in 2025, there is an expert opinion which has been given in 2025 March. This emphasizes the importance of oral probiotic supplementation in managing conditions like GSM, and it highlights the use of probiotics, especially the lactobacillus species, which has this beneficial effect on restoring and maintaining the healthy vaginal microbiota, thereby aid in treating GSM. They help to prevent and treat recurrent UTI by increasing the lactobacilli levels, inhibiting the candida growth, maintaining the vaginal pH, all these things. And symptoms of GSM of menopause, like vaginal dryness, itching, and recurrent UTI, can be alleviated through combination of lactobacillus-based probiotics and estrogen therapy. Now, what about the safety and limitations of use of probiotics? Overall, probiotic and prebiotic supplementation is considered safe mainly in good, healthy, immunocompetent individuals. However, such things are generally not recommended for high-risk patients like immunocompromised individuals, those who are critically ill and in intensive care unit or post-operative or hospitalized patients, because there is a chance or risk of infection. Certainly, the current available studies on probiotics and prebiotics have a number of limitations that cannot be underestimated when drawing conclusions on their use. Say, for example, many studies have evaluated population that are too small, or they have considered the duration, which is very short. So we need to look at larger study with a larger population also. Now, before I conclude, I would say there are a lot of queries in front of us. Of course, I hope it will be cleared soon. Now, does the gut microbiome influence the timing of menopause or the symptoms of menopause through its action in recycling the estrogens and other mechanisms? The gut estrobolome, as I told you earlier, it may provide a source of estrogens for the vaginal microbiota, which play an important role in the genitourinary health, and they are profoundly impacted by the loss of ovarian estradiol during menopause. Now, another important thing is that does menopausal hormone therapy impact the gut microbiome favorably? And in turn, do the gut microbiota modulate the effectiveness of hormone therapy? And third thing is probiotics can colonize the vagina, improve the vagina recovery rates, but identifying how the probiotics can remain effective long term. That is how long you have to give, how long the effect will persist. This is really crucial. Only then we can say that it is going to be very successful intervention. And another important thing is that it has been challenging to determine the reasons behind the success or failure of any study because of the variation in the strains of lactobacillus that we use, the dose that we are using, the type, whether orally or vaginally, and length of intervention. All these things must be common when you are doing a study and comparing it, and to make sure that these pro or prebiotics are definitely going to be recommended for the use of managing genitourinary symptom. But I am sure with in future, definitely we will get more and more studies which prove that the pre and probiotics can improve the symptoms of GSM. In that case, we will get a very good, cheaper, safer alternative to either estrogen or laser or any other complicated thing. It will be almost like a natural therapy. Thank you very much.
That was nice, Revati, madam. I
Thank
think,
you.
and I felt this was a complex subject, and also, the very less evidence and very less faith of people. And you were the best person to read up thoroughly, and then and then give us the gist of it, because
Thank
I
you.
really believe that you can do that. Thank you, Revati, madam, for
Thank you.
that.
Thank you.
So I must tender a very, Anjana, मैं बोलूँ ना अभी, ठीक है ना?
हाँ जी, yes ma'am.
क्योंकि
Now I invite Dr. Shobha Guddi for the prescription writing and give us advice on this. Ma'am,
No,
please.
I don't need an invitation, and I thank Anita ji and Ragini for this opportunity. And I am very distressed today because my laptop is not working. So as I have been posting in the chat box, and I have told both the president and secretary, excused myself, and we shall be doing a verbal discussion like a panel on the on this subject, and we will write in the chat box only some kind of prescription, and later on we will present in the next class about the complete prescription in this patient. So let me present. I just wanted to take concurrence of all the experts present here that when we say GUSN, the symptoms are often the triad of vaginal dryness, burning, and dyspareunia. Am I right, or is there any other
Yes.
thought on this?
Yes. Yes, and the dysuria also.
Dysuria also, correct. So
Yes.
dryness, burning is what I meant, that only. I meant burning, spontaneous burning also, and burning in micturition also. And actually urgency, urge incontinence also get added, but these are the principal symptoms. Sudhaji, you wanted to say anything?
Thank you, Dr. Shobha. No, very right. I think you are very right. This all three will include in GS.
So, and they are all very, very distressing symptoms for the woman,
Yes.
actually. And it
Very
really,
distressing symptoms, very common in Indian females. Only they come out only when you ask them leading questions. But I tell you, when you sit in OPD, it is one of the most common symptom in postmenopausal females. The more they are away from the menopause, the worse is the condition, and they try to live with this because they think that this is a part of menopause.
correct. They take
And
it as their fate,
And we
actually.
can even use the word of itching also. Many a time they
yes,
represent with a lots of itching
Irritation,
also.
correct.
Not only the dryness.
The dryness leads to that sense of
The
itchiness.
itching.
Yes,
Yeah.
correct. So it is the primary are these three, and secondary to that will come as itchiness, will come the dysuria part, the urgency part, etc. And of course, secondary to dyspareunia is a lot more than is a lot more problem there. So I present to all of you a 67-year-old lady who has severe dryness now. She has burning, and she is very distressed about the inability to have comfortable sexual intercourse. And then she had been on a combined HRT for at least for 5 to 7 years between the age of 50 and 60 years. For the past 5 years, she has not been on any therapy, and she doesn't have any specific comorbidities, especially except for mild diabetes. She is having slight glucose intolerance. She is on some oral anti-diabetic treatment, and the sugars are well under control. She is maintaining good
Why was she put
BMI.
on HRT? The 10 years?
She had vasovagal symptoms.
Okay.
She had vasovagal symptoms. She had hot flashes, and she has taken, because she was crossing 60. Then it was stopped. Then it was never revisited again, and she is clearly saying that the gynecologist did not feel strong enough to continue the MHT, and so she also felt afraid, and she has stopped it. And now she has developed all these vaginal problems. And when we take the past history, she does say that she had some problem, so for the past few, maybe 1 or 2 years, but it was not this bad. And she has been regularly using moisturizers and lubricants, but unfortunately she has not gone back to the gynecologist. So in this case, when we have very clear directives about not continuing MHT more than 60 years, which sometimes I feel it may not be very right to do that, to stop it off after 60 in all patients. So here what we could have done to reduce the damage for this lady. Dr. Jyoti, should we?
Yeah, okay. So, reducing the damage, the fact that she was on systemic MHT would have reduced the problem during the time that she was on the
During the time.
hormonotherapy. But probably when the MHT was stopped, or when the systemic MHT was stopped or tapered, she should have been told that if she develops any other symptoms, she should come back, so that she didn't feel that she had no option in terms of her GSM.
Correct.
So the counseling is important, that in any case, like we've said many times before, these women should be seen every year for general health and general screening, not just cancer screening, but for non-communicable diseases, etc. She's diabetic, so she may be seeing a physician already. And she should see a gynecologist also once a year. That was the one thing which perhaps if she had seen a gynecologist in the intervening years, they would have asked about her symptoms. Now for her, local estrogens are definitely the best choice, because they will relieve her symptoms better than anything else. And she has already tried lubricants and moisturizers. They're obviously not working. So she should be given local estrogens, and there is no age bar to giving local estrogens, that, like systemic MHT, we don't want to start after 60. That is not there for local estrogens, and we can start it even in the later years.
Yeah. So at the age of 67 years also, we can start her on low dose vaginal estrogen.
That's right.
Rather than DHEA or ospemifene. This should be the first choice, vaginal estrogen. And we have only this choice. We have either conjugated estrogen, or we have estradiol. And we have estriol also, as you said. So we can choose either of the three, whatever is easily available for us. But given the choice, which one should we use? Suppose all is available, then should we use CEE, or should we use estradiol, or should we use estriol? Yeah.
Yeah, I would say if her symptoms are very severe, start
Very
with
severe.
CEE, because CEE gives the quickest relief of symptoms, because it is a slightly more potent estrogen than the estriol cream. So women with
What
very
about
severe symptoms.
estradiol? What about estradiol?
Estradiol is available as a tablet. Sometimes you get it, sometimes you don't. So if you get it, estradiol tablet is also fine.
We have
Either
estradiol cream, isn't it? Don't we have
no,
estrabet cream?
Here
that
I
is
want to.
That is no, that is
that is
No,
for
no.
transdermal. It's not for vaginal.
transdermal. It is
Okay.
not vaginal.
Okay.
So yeah, so I would give her CEE cream to
CEE.
begin
Okay.
with,
Okay.
and then shift her on to estriol.
Sudha, what do you say?
Yes, very right, Dr. Jyoti has said, because it has been seen in, if you give this CEE ointment, they say in the blood, the estradiol levels are little more higher than what you use in estriol. Estriol is the, least potent drug. The best one is the estriol. But if she has severe symptoms, very rightly, Dr. Jyoti has said that to start with, CEE for some time. But then later on, we must shift to, estriol, which is safe, which is least potent. And then I tell you, in every meeting, I always say, though Dr. Jyoti has also stressed on about the sexual activity, I spend good 10-15 minutes in, doing counseling. They have so many myths about this. So if you tell them that this is a part of treatment, if you don't think about your spouse only, this is a part of treatment, a very good part of treatment. I tell you, they would come back with good results.
One thing for the estradiol tablets, it is written if we are using estradiol, we have to do the little bit surveillance, because it is absorbed more than the estriol and the C, number one. And some estradiol tablets which are available, they are the part of the MST, systemic MST. They are not the part of the local MST. So we have to be very careful whether we are using the estradiol tablet, which is a part of the systemic MST, or not.
Yeah, so it is not the oral preparation which is to be used. The E2 vaginal tablet is available, and that is the one to be used for GSM.
Yeah.
And another thing is that the tablet, when we use, the level at which it is kept in the vagina also matters the extent of absorption. isn't it?
Yes.
So the
Yes,
Yeah,
we
I
have to
think they have
push it
to.
in the upper.
Yeah,
Ah.
they have to keep it in the upper vagina
Mm.
where it is
Yeah.
better absorbed. Is it not? Is it not? Yeah.
Yeah.
And as such also it becomes very thin and less vascular after menopause. So we have to improve the optimize the absorption. One practical question which I have is that the woman asks whether she needs to continue the lubrication, the moisturizer and the lubricant along with this this our local estrogen cream. Yeah.
No,
So
it's not required.
not required, and it may come in the way of absorption of the drug also.
Yeah.
So
So only thing is, if she is having dyspareunia and she wants to use a lubricant during intercourse, that is okay,
that
but
is okay.
not as a treatment for her
Yeah.
dryness or her GSM
Yeah,
symptom.
that is what I usually tell that during the act maybe it is okay to use. The
And
other
one
thing I
thing,
want, yeah,
Shobha, one thing we have to tell them very clearly, if they are using estrogen application during intercourse, the husband has to use a condom. Because this estrogen cream that cause the problem and the ulcer like on the penis.
correct,
A
correct.
very important thing to tell them.
But it is also possible for them to time it differently, na
Yeah.
Ragini?
Yeah,
वो भी
yeah,
तो कर
that's okay.
सकते
Then
हैं.
it's okay.
Hmm.
Only if we
Because
have
I
to tell
think,
them and consult them, only then they can do
yeah,
this thing. Huh?
yeah, I understand. But what I have kind of understood, because I'm not a specialist in that area, what I have understood is with older age, the use of condom is less kind of,
Yes.
comfortable. And
No,
also,
totally agree with you, but we have to
yeah,
tell this particular point to them.
correct. No, I understand that. I know what you're trying to
Because
say.
what
So
I am
I
saying you,
usually tell them,
I
correct,
have
correct.
seen Shobha, one patient, they are using this estrogen cream as a substitute for the lubricant.
Correct.
They don't
That
realize
is.
that it is a medicine.
Yeah, so it is using as a lubricant also and the medicine also.
Okay,
So there
okay.
was a problem arise.
Problem. Correct. Okay. So the other one more delicate point is many times when they come, we find a little breach in the skin of the vulva, redness, inflammation, fissures, and because of the dryness, it becomes so delicate, and even insertion of a speculum sometimes. And then today I had a patient who had very severe, actually senile vaginitis. So I wanted to bring in 1 or 2 minutes of discussion on managing senile vaginitis and then the MHD. So what should we do? Should we use an antibiotic? Should we culture the discharge that we see? And when can we start the estrogen cream? Are there any thoughts on this? Yes.
If nobody else has a comment, then I would say you can actually ask them to apply the estrogen on the vulva also. So they don't have to insert it only vaginally. So they can take a little bit of the estrogen cream on their finger and just apply it on the vagina for a few days. And then when it becomes easier, then insert it intravaginally. I don't think you need to give these women antibiotics because unless there is a clear-cut infection, most of it is not. And we really have to restrict the use of antibiotics, antifungals, just without even looking at the vulva and vagina.
Correct. So I have actually cultured the vagina today, the discharge. She had a lot of tenderness. There was a lot of tenderness in the vagina. So I felt that there is an inflammation ongoing, and I have tried to give her an oral anti-inflammatory. Locally, I'm planning to start the MHD, the estrogen, as soon as possible. She has to come back with some of the investigations. At this point of time, I was also thinking of starting her on a probiotic. So, Revati madam, I'll go ahead and start an oral probiotic because I am planning on vaginal estrogen. Is it possible to use both the products vaginally, or should we go for oral and vaginal?
Yes. No. You can use both vaginal estrogen with the vaginal probiotic also. Or even this oral probiotic with the vaginal estrogen also does good.
Good. So we can use for up to 6 weeks. Will it help if we use up to 6 weeks the oral probiotic therapy, or do you recommend a longer one?
A little longer only, not 6 weeks alone is not sufficient. You can continue
6
because
weeks
we
to
do not know
because
exact duration
nobody,
of the action.
yeah, right, nobody
It's not
tells
written.
all these things. So so these products are, yeah. Any other input, please,
Actually,
on
ma'am,
this?
pharma company, they say at least if you're using oral prebiotic, then it should be at least for 3 months.
Okay.
They say 1 BD for 1 BD to take till the symptoms regresses.
12 weeks.
12 weeks. And after that, 1 OD for 3 months. Then you get a perfect,
Yeah,
that is
correct.
their dose recommendation.
Correct. So
That is a
Anjana, I have,
recommendation by whom?
Huh?
Recommendation by?
No idea, madam. They
this
say
is only the manufacturer's
Yeah.
play.
That is
No, that's okay. That's okay, because these are all, they are not harmful. So we will be able to use them. So I have found benefit with 6 weeks, but more with 3 months, as Anjana is saying. And the maximum I have been able to use it for 6 months, because beyond that I feel, most often they are okay with whatever we are doing, but what is helping them we will not know. We have, so at what point of time shall we recommend the laser therapy? Because after this we'll go back to the other products, the other hormones, before we wind up. So at what point of time any of you would recommend? Because I again today I read up all the evidence ना रागिनी जी, तो मेरे को वो recommendation कहीं नहीं मिलता है, और सब जगह यही लिखा रहता है कि
नहीं, you are very right, Shobha.
कि
Because
अभी तक एविडेंस नहीं
RCTs
है,
are
it is
not
not
available.
supported by evidence. So
Because
नहीं,
RCTs are not available.
not
It
available.
is not. This is a very big thing, and
Hmm.
it is not in
So
most of the
correct.
medical colleges.
हाँ,
So the all groups are very small. But the two things what I found, as Dr.
yeah.
Jyoti ji has also said,
Hmm.
recently, say 2 years back, I bought that pelvic exercise chair,
ठीक है.
and I really found that chair is too good for these
Many
women.
people are saying that the
Yeah.
chair helps
So
more than the
chair
drugs.
helps a lot, because of all those pelvic muscles which are has a dragging sensation, less vascularization. It increase the vascular flow. And what I found, even the menopause, because of the menopause, with the urgency of the urgent urinary consequence comes, it really, really
There is
improved.
relief. There is relief. There is relief.
When
Yeah.
it is not improved by the laser, I'm telling you very clearly,
Correct.
because SUI, laser plus minus, only if it is a very milder variety, along with all those PRP, yes, I'm getting a
Correct.
result. But menopausal urgent UI, this this pelvic exercise machine, high fem chair, whatever you can say, it's a wonder and wonderful thing. And along with that, in women, if they have a more of a vaginal itching and the problem, they are the candidate for the lasers.
Okay.
But if they have, along with that, they have this sexual problem also. So like in the older woman, younger women, we
We
give
can offer them this therapy. Correct.
we give the pleasure shots, na? These O shot and all those pleasure shots, like that we give those platelets to surrounding introitus, in the vagina, and around the clitoris, and it gives a wonderful result. So I can't say the only thing, but I can say this only carbon dioxide laser in the vaginal atrophy cases have a very wonderful results. I can tell you, one of my patient, when she came, it is very difficult to introduce even a finger. So gradually, with a very small probe, we have two type of probes. I started with the smallest probe. She bled like anything, and it was horrifying. Anyway, second time when she came, she was also afraid, and myself also afraid. But we did it, and I am able to introduce the smaller probe up to half. Then gradually, up to 3 or 4 sitting, I am able to do with this, and I left it. And called her after 4 months. And finally, at the end of the treatment, I am able to introduce the broader probe also. So
that's
the thing
very
is
good.
that
Yeah.
the
Ragini, laser is never a first line, no? Laser
number
is
of
never the first
patients
line.
are very less.
No, that is the, we have discussed the first line, Revati ma'am. We started the first line. So what we have gone is the right way. And now, after that has not worked only, we have asked Ragini and she has given an input. And thanks for that, Ragini. I wanted to ask Anita, Anita ji. Yeah, that's what I was coming to you, Anita ji. Please, please. Yeah.
Ragini, for PRP, do you means are you doing in general anesthesia or just local?
No, even I don't give the local. I tell the patient, you will feel the little bit discomfort.
Okay.
I put the numbing cream on the vagina, on the sorry, vulva, introitus and the outer. So it has a little bit less symptom. I cannot give lots of local in the whole whole of the vagina. The that much of the injection I have to give the PRP only and come out. So I give a counseling to them. If I give you a 5 injection of the local, I'm giving you a 5 injection of the PRP. So why you want that local? I never give local. Don't go in the any GA. It's OPD procedure, in and out, and patient was explained properly, and usually they get. But most of the patient, if I do the outer limit, that the near clitoris and all, then I give the local xylocaine, because it is a very, very sensitive area. Then patient feel pain afterwards. And third thing, mostly I give this PRP in the vagina after my carbon dioxide laser with the low energy. I don't give a very high energy to heat, because if it is too much heated, my PRP will be denatured. So very low energy, it causes its hole inside the vagina, and I just push the PRP inside, no injection, nothing.
Definitely, it is beginning to sound like definitely there is a role in more complex cases where there is also anatomical distortion. That is the way it is coming across. So,
No
हाँ
anatomical distortion.
नहीं नहीं आपने कहा ना वेजिनल स्टेनोसिस वगैरह था है ना
ये तो मैं उस पेशेंट का बता रही हूँ, that
हाँ
particular
हाँ हाँ but
came
then
80-year-old
yeah
woman having a
when
severe DSM, but we
हाँ
can prescribe in a younger woman also, and it's a wonderful
हाँ
result.
सही बात है मगर आज का जो जीएसएम में है here what we are trying to convey to the audiences whenever hormonal therapy do not give the desired results we can offer
Yes.
them this saying that it is not evidence it is not very as much evidence as that but patients do not understand the evidence based medicine concept but we can tell them that relief is possible with this modality. Anita ji, would you like to add to this before I go to the next, the last part with Jyoti ji and Sudha ji?
Fine.
Shobha, I have to go to labor room, please.
हाँ ठीक है ठीक.
One of the patient was having a fusion of the both labia minora and majora, and after local application of estrogen, gradually it was
Correct.
so nicely corrected that even a vaginal introitus introduction should be done.
Correct.
I just
Yeah.
want to add one thing, madam. I am as an oncologist, so I get post-radiation patients. So there is always an atrophy, and after radiation, I give all my patient dilators. So they really do very wonders. Give them vaginal dilators and give them some lubricant, and
But
probably
don't you use estrogen in them?
if they're having something very, then we use estrogen locally also. But vaginal dilator is must. If they stop using it, then it goes for stenosis also.
Correct.
And so in
So,
even 2-3 menopausal patients that had come to me, just they were relatives. They were having the same issue.
I think they will deserve some local because then they would have lost the hormonal function, no, totally. So they will require. Yeah. So the last part of the discussion is ospemifene already was very well discussed earlier. So and the availability is in question. So I just wanted to bring in that particular situation where a woman has had breast cancer and has undergone surgery and then and treatment and local estrogen becomes a problem or any estrogen dependent cancer for that matter. So low dose estrogen can be used was the message conveyed. But suppose they are on tamoxifen or they are on letrozole, aromatase inhibitors for the chemotherapy following the breast cancer surgery. Does it change our approach in any way? Wanted to ask because today we are having a lot of women who have had post breast cancer. It's commonest cancer for us. Yeah, Jyoti ji.
Yeah, if they are on aromatase inhibitors, this is the concern that, there could be a problem with the local estrogen cream. And that is the reason why these women are usually given just moisturizers or lubricants. Moisturizers are better than lubricants because they attach to the vaginal surface and they act for a little longer. They usually got some hyaluronic acid in it, so
Yeah,
it's better to give them moisturizers.
moisturizers are better.
Yeah. But if women are very much disturbed by it, then you could consider giving them low dose estrogen for a short duration. The ones who have completed their therapy, it's easier. But when they are on aromatase inhibitors, that is where the role of DHEA and
DHEA
osteomephrine, and
comes in.
that is why they have, they've looked at it in this particular group, and it seems to be working well for their symptoms without increasing the recurrence risk. So we have to hope that the molecules come back to our country soon. So
Correct.
perhaps
I
we'll be able to
also
talk to
feel
them also.
DHEA local will be real boon for
Yeah.
I feel that.
Yeah.
And what about tamoxifen women who are on tamoxifen, and can we use local estrogen for that?
We can use, but there are concerns that the effect of because of the effect of the aromatase inhibitors, we are not going to get as much effect because of the desensitization of the receptors. So this is the dilemma that is it going to increase her recurrence risk without actually giving her much of relief because of the use of the agent.
Correct. That's what low dose vaginal estrogen will have actually grade 2C recommendation even in women who are on tamoxifen, I think so, right? And they are not associated with an increased risk of breast cancer recurrence. So that is what we but when they are on letrozole aromatase inhibitors, then they should not be, because today I had exactly such a patient. I had a woman who was on letrozole, and there was premature menopause for her because of the I think she had undergone a risk reduction surgery as well. And somehow she had a THBSO also, and she had breast cancer treatment also, and she was put on letrozole. And then she had menopausal symptom. We do see such women also. And then I was kind of at a fix, then what can we do? So then I think, mm, as you said, a short duration low dose vaginal estrogen, maybe it is okay. The other thing which can be done, Jyoti, in these cases is consult the onco person whether we can change the AI therapy, letrozole therapy to tamoxifen. Suppose suppose it does not change the outcome of the management. So that is another thing. Sometimes we can do that and then go for a better local estrogen therapy, but it can become challenging. Yes.
Yeah,
So
and most oncologists will tell their patients not to use the local estrogen cream.
correct.
That is my experience.
Yes,
However
exactly.
much you talk to them or show them data, they are not comfortable with it. And so,
Yeah.
since they are the primary people treating the patient when she has a cancer, patients also, are scared when their oncologist doesn't give the go ahead.
Yeah, thank you. I think that was all from my side.
What
And
is your suggestion, Anjana?
yeah,
Any oncologist, Anjana, what is your
अंजना क्या बोलते हैं? सही बात.
I don't get breast cancer patients, but sometimes because of bleeding they come, but hormones though refuse. Every time they refuse. Sometimes they complain about hot flushes and everything. One of the patient I tried tablet clonidine, but they Oncology it is refused, but other cancer, carcinoma cervix, definitely you can give hormone. If they are having adenocarcinoma of cervix, then it is not recommended. But if she is having squamous cell carcinoma, vaginal, vulva, you can give. If it is a vaginal melanoma, this I've never seen a vaginal melanoma patient till menopause because it's a very dreadful condition. But in those cases also you can't give hormone therapy. And germ cell to girls, if they are going in ovarian insufficiency, you can give them hormone because it is not hormone related. But sex cord stromal you can't give. So it's always a dilemma because looking into the pathology, we have to decide.
I
There
think,
was one question that can you name some vaginal moisturizer?
yeah, correct. Even I saw that question. Thank you, Bipasha, for that. Yeah. Anybody
I'm back.
has? You're back? Give us
Yes.
vaginal moisturizer. Multi था क्या? जल्दी delivery हो गया.
हाँ बस मेरे को तो झांकना होता है ना. हाँ जी बताओ.
Birthing is so beautiful. It yeah. Tell us some moisturizers which are being dispensed at your clinic.
So, what I like, there was a used to be pelvic gel used to come. Now it is not available. Nowadays I am using Varna gel. That is a
Varna
nano
gel.
silver. It has a little bit microbial activity also. I am really happy with that.
नहीं ये just
I
now
use
we
it
were
as a
discussing
moisturizer also.
कि moisturizers are better than lubricants. That's what. So you are telling about moisturizers only, right?
Yes.
Yeah.
Yes.
Yeah.
The
Correct.
West Coast is having
it as well.
veggie moist, madam. That is also good. West Coast company there is having a veggie moist. I don't know where it is in all over India or it's local Ahmedabad, Gujarat. It is having a veggie moist and it comes in a small tube. It is one time use and throw. They send a whole box about it. So that is also very good. Veggie moist.
Yeah.
Shobha,
Yeah.
I just wanted to know, anyone has any experience of using isoflavone gel?
Yes, me. Wonderful. Icerin
Wonderful.
gel, but
Also
nowadays
used.
it is
Now
not
it is
available.
not available.
Not available.
Now it is
Wonderful.
not available. Previously it was available. I also had used and it was giving also very good result. Yeah.
Very good result.
उसमें सच में आइसोफ्लेवॉन रहता है सखी साथ में मॉइस्चराइजर भी रहता है सॉरी मेरे को ये नहीं समझ में आता कि वो कैसे लोकली एक्ट करेगा
नहीं, you know, Shobha, I don't know. It is not only the moisturizer. I think it has some thing. Although I am not in a flavor of I don't give my patient any soya capsule or anything. I don't give. But this Icerin gel, when I used specifically in the patient who are very reluctant to take the Evalon cream, they really have a very good result.
Yes.
So I started giving it a
Okay, let
Icerin
us
gel.
hope it comes back. So today is a prescription workshop of all, yearning. Ki that should come back. This should come back to our market.
Yeah, I have talked recently to the Gufic people. Why
Yeah.
don't you come with a full bouquet of the menopause thing and the sun also?
Correct.
What you're talking only about the
No, I
estradiol
think people are thinking of
and
it because now because of our repeated webinars, many people have started prescribing maybe. Yes, Jyoti ji. Yes.
No, I just want to say I'll need to leave now. So thank you very much.
Yes. We are at the end and we really thank you so much for being today here. You and all the
Thank you.
experts, Sudha ji, Anita, Anjana and Revati madam, Bipasha, Ragini, all of you
you
together
too.
have managed the workshop.
You too.
And all the
so much.
delegates.
Thank you.
Thank you.
And all the
Thank you.
delegates. Anjana ji, please
Thank
give
you.
the vote
Thank you.
of thanks. Thank you,
Bye.
Anita.
Thank you, Jyoti.
Anita,
Paresh
please.
also.
Thank you.
Yeah.
Thank you, Paresh.
Thank you.
Before
Bye-bye.
winding up, just I would suggest one thing.
Mm.
Those who are attending this webinar, please, I just would like to convey that we are doing LBC pep test with HPV DNA testing with only 1,000 rupees in collaboration with Metropolis. I'm not happy to say that so many of society people are not aware of this. So please convey this message, give best advantage to your patients.
Ji.
Only 1,000 rupees you can get LBC pep test plus HPV DNA done by Metropolis. So
Thank
take
you.
the advantage and give advantage to your patients.
Thank you. Can I request this as a message or a mail or a WhatsApp message to our groups or our mail IDs so that we can.
Sure.
Please send this message.
Yeah,
Thank
Yes.
you. Thank you.
Dr. Anita, I think you should frame a message. You and Dr. Ragini can frame a message
It has
and ask
gone many
Paresh
times.
It
It
is
has
to put
gone
gone.
in
many
all the
times.
societies.
Shida, it is gone
It
to
has
all the
gone many
president
times
secretaries
to
of
all
the
president
societies.
secretaries.
Now would like to give the numbers to Metropolis also, and they will contact directly to the doctors. We
Yes.
have given the
I
numbers
think
to President Secretary to Metropolis Lab also.
And Paresh is in all the societies.
Right.
He's in all the groups,
It is
local
already
societies.
sent, but then also some
I
are.
think Anita ji, we will make a very tempting flyer for that. So it will, मतलब जो कि लोगों को catchy
Attractive.
लगेगा, we'll make a flyer.
Sure.
Yeah.
Okay.
Okay,
Bye.
ji. Okay. Bye.
Thank you.
Bye-bye. Thank you.
Everyone.
Thank you, everyone.
I thank Dr. Anita, Dr. Ragini for such a nice initiative, and it
Bye.
was very nice webinar today, especially the prescription writing, and Dr. Shobha gives a nice what we can say step pattern ladder what we should write and how should we proceed. So thank you everyone, and I thanks Menopause Society to take such initiative. Thank you everyone. All the faculties have done excellent lecture. Dr. Ragini, Dr. Revti, Dr. I think so, Jyoti have done a very good job. Thank you very much.
Okay.
And thank you, Anjana, for comparing it in such a short notice. Thank you so much.
Thank you.
Okay, ji. Bye.
Bye.
Second Wednesday of next month, we will
Yes,
meet
sure.
up.